My name is Michael Manz. I'm Director of the Department of Gastroenterology, Hepatology and Endocrinology and President of Hanover Medical School, Germany. I have a long-term interest in autoimmune liver diseases, which are rare diseases of the liver. There are three major autoimmune diseases of the liver: primary biliary cholangitis, PBC, primary sclerosing cholangitis, PSC, and autoimmune hepatitis. The first two target the bile duct, the latter targets the main liver cell, the hepatocyte. We have seen little progress in recent years in PBC. Standard of care has been ursodesoxycholic acid, UDCA. This is a very well tolerated therapy. However, 40 to 50% do not respond to this therapy and need alternatives. Some time ago, obeticholic acid was approved as second-line treatment, and there are data showing benefits of bezafibrate. In the future, a combination will be tested, but other targets are under investigation, like PPAR antagonists or FXR receptor agonists, and we will see these data in the near future. The principle is that we try to do basic research to understand more about the etiology and pathophysiology of these autoimmune liver diseases. This is particularly relevant for the second autoimmune liver disease, PSC, primary sclerosing cholangitis. Here we have very limited data on etiology and pathogenesis, and the disease is also called the black box of hepatology. The only disease that has an impact on the natural cause, the only procedure, is liver transplantation. Several medical therapies under exploration, like ursodeoxycholic acid, or even work on the microbiota. We understand that microbiota have a major impact, in particular on patients who are having both ulcerative colitis and primary sclerosing cholangitis. Hopefully these therapies will lead to approval in the near future. Finally, autoimmune hepatitis has been the first disease of the liver where medical therapy was shown to improve survival. This was thanks to steroids. The standard of care is steroids together with azacitidine, either alone or in combination. If this therapy fails or is intolerant, we may run into problems. The topical steroid budesonide may be used to reduce side effects in non-cirrhotic patients. None of the other therapies used for second-line treatment for treatment failures has been approved yet. It is our understanding that we use mycophenolate, MMF, if there is intolerance to azacitidine. We may use others like tacrolimus and cyclosporin if there is treatment failure. Recently, biologicals have been are under evaluation, like antibodies to TNF and B-cell antibodies. In particular, recently there has been emphasis on developing B-cell therapies, like rituximab and novel antibodies that not only target B-cells but also the BAFF receptor. Finally, regulatory T-cells have become into the focus of autoimmune diseases in general and autoimmune hepatitis. And here, at present, the adoptive transfer of Tregs or low-dose interleukin-2 to stimulate regulatory T-cells are under investigations and are promising approaches to treat not only 50 to 80%, not only those, but also successfully treating and preventing progression for all of those patients. Thank you very much.